Welcome back, everyone. We are going to continue our discussion on the endocrine system, and we are going to briefly discuss the endocrine pancreas, and we're going to also talk about diabetes. So when we talk about the pancreas, it's an abdominal organ. It kind of sits behind the stomach, so posterior to the stomach, and the head of the pancreas sort of fits into a little loop of bowel that we call the duodenum. So it's an abdominal organ. It actually plays a role in both gastrointestinal function and the endocrine system. So the pancreas actually has two large functions. It has an exocrine function. This is the GI function of the pancreas, whereby it's releasing substances into the bowels. It's not going into the bloodstream. So this is releasing, and this would be like digestive enzymes. Bicarbonate. Into the duodenum. So it has a digestion function. The one that we're actually going to focus on today is the endocrine function of the pancreas. And this is the hormonal function. Now, if you look at the anatomy of the pancreas, there's not like a half of the pancreas that is exocrine and half that's endocrine. Both functions are sort of scattered. They're not really scattered throughout, but they are mixed with each other. So the endocrine pancreas, if you look at the actual cells of the endocrine pancreas, there are multiple types of cells. And because it's endocrine, if you look at the histology of the endocrine cells, they are in very close proximity to blood vessels so that the hormones can enter the bloodstream. The groups of cells that are part of the endocrine pancreas, so the endocrine pancreas, the collections of cells are called islets of Langerhans. And within these islets of Langerhans, sometimes they're just called islet cells. There are multiple types of cells within there. And these islet cells, there are alpha cells. Each one of these produces a different type of hormone. These alpha cells produce a hormone called glucagon. And this is going to, be in response to low blood sugar, or blood glucose is better. They're the beta cells. This is the one that we're going to sort of focus on here. This releases insulin, and this is in response to high blood glucose. There are the delta cells. That's the Greek symbol delta. And these are going to produce somatostatin. Somatostatin is a hormone where, if you look at the prefix of it, it's soma, body. Statin means to stop. It essentially stops and inhibits all the other hormones that are being produced. And then there are the F cells. I don't really know what these do. I'm just going to say, don't worry about this. I think it makes some sort of a polypeptide, but I don't really know. We're going to focus on the beta cells. Now, when we talk about insulin is really about trying to take the sugar from the blood and give it to the cells that need it, or the glucose from the blood and give it to the cells that need it. In order to do that, the majority of the glucose gets out of our blood system through these things called GLUT transporters. They are glucose transporters. So if you look at the GLUT, so we call them GLUTs. There's all different types of GLUT transporters. The one that is most important for our purposes is GLUT4. There's GLUT1, 2, 3, 4, 5. The only one that is insulin dependent is GLUT4. So this is the most important one that we're going to talk about today. GLUT4. So essentially, how this insulin is going to work is that we're after a meal. So there's going to be sort of after a meal, our GI tract, we break down the sugars, and those simple sugars like fructose, glucose, galactose, they get absorbed into the bloodstream. It is a GLUT-dependent process to get into the bloodstream, but it's not insulin dependent. It's only getting out of the bloodstream that is insulin dependent. So after a meal, we take all of that sugar that we've ingested. There's also fats and proteins, but we're going to focus on the sugar. The glucose is going to go into our bloodstream, and our blood glucose is going to rise. That's a normal response. Blood glucose rises. And as a result of blood glucose rising, this is going to directly stimulate the pancreas, specifically those beta islet cells in the pancreas, to release insulin. So we stimulate. There are other stimuli for the release of insulin. The pancreas to release insulin from the beta islets cells. Okay, so we are going to look at, and it's going to put it into our bloodstream. So here's our bloodstream, and what we have is our blood sugar. I'm going to just put as little green dots in our bloodstream. This is all the blood sugar. It's high blood sugar. So we want to take that sugar out of the bloodstream and give it to the cells that need it. And the insulin would have been released by the beta islet cells, and we're just going to draw that as these little triangles, blue triangles. This is going to be insulin. And I'll just put this as glucose. So this insulin will be released after the meal. And it's going to help bring that glucose out of the bloodstream. The way that it does that is that attached to these small blood vessels, it's going to be in close proximity to our body tissues, whether it's a muscle cell or a liver cell or adipose tissue, whatever it happens to be. There's going to be a cell that's here that needs that blood sugar, or that needs that sugar to for its energy. And on the surface of the cell, there's going to be a GLUT transporter. Maybe I shouldn't have drawn it like that. I'm going to draw it, actually, I'm going to draw it so that this triangle fits in. How can I draw that? How am I going to? I should have drawn it upside down. We are going to draw it like this. There. I'm going to draw it like that. And I could have made it a lot easier just by drawing it properly. Oh, well. There we go. There's our little GLUT transporter. And it's going to come in and it's going to bind to this little spot here on this insulin receptor. So this would be an insulin receptor, or a receptor for insulin. Now, inside of this cell, there are these little storage vesicles with GLUT4 on them. The only way to get these GLUT4 transporters to work to bring glucose into the cell is to have insulin present. So these little cylinders are GLUT4 transporters, and the whole thing is a storage vesicle for them. And they just sort of float around in the cytoplasm of the cell. And once there is a signal that insulin has become attached to the receptor, it's going to cause this GLUT4 transporter to translocate to the surface of the cell and fuse, and all of those GLUT transporters are going to be placed on the surface of the cell. Once they're placed on the surface of the cell, now it can work. Without insulin, that vesicle would not have been translocated to the cell membrane. So this glucose can now enter the cell, and it brings the blood sugar down. So glucose enters the cell, and it can be used for ATP, it can be used for storage, whatever it happens to be, but it can be used for either of those things. And that brings our blood sugar down. Bring blood sugar down. There is one insulin independent mechanism to get glucose into muscle cells, but it isn't the major way that we get glucose out of our bloodstream. Without insulin, that glucose would stay in our bloodstream. And that's actually a big problem. Because glucose is not only toxic to our blood vessels, it also, because it's a dissolved solute, it acts as an osmol, and it draws water in, and it actually dilutes things like our urine and makes us dehydrated, and it can have some really big downstream effects. So what we're going to do is we are going to discuss what happens when either we don't have enough insulin, or what happens when insulin doesn't work quite as well as it should. Or what happens when the cells don't respond to the insulin as well as they should. And that gives us a condition called diabetes. Now, there are multiple types of diabetes that we can actually get. The type of diabetes that we're going to talk about is a type of diabetes called diabetes mellitus. Diabetes mellitus was named before they knew exactly what caused it. So there were actually two types of diabetes. Diabetes mellitus, if we actually look at what these words mean, diabetes means siphon. One of the things that we're going to see in diabetes is that people who have it tend to pee a lot. They tend to just keep on peeing like a siphon. And then mellitus, if you look at the root word of what mellitus means, it means honey-like. Honey-like. If you speak French, you know the French word for honey is similar, or has like a similar root, honey-like. There is also another type of siphon disorder or diabetes disorder whereby they call it diabetes insipidus. It actually has nothing to do with insulin whatsoever, but it would cause people to pee a lot. But diabetes insipidus means tasteless. And so one of these conditions historically would cause someone to die, and the other one wouldn't. So diabetes mellitus, if somebody had diabetes mellitus, they would generally die within a week or so. If somebody had diabetes insipidus, they were going to live as long as they stayed hydrated. And the way that the doctors actually figured out whether somebody had the form of diabetes that was going to kill them or they were going to live was exactly the descriptor of what the siphon was like. So they would get a urine sample, they would taste it, and if it tasted sweet, they knew the person was going to die. If it didn't have any taste whatsoever to it, they knew that the person was going to live. Luckily, we have more advanced testing now that we don't need to do that. And we know exactly what is causing this diabetes. So this is diabetes mellitus is the only one we're going to talk about. This is a metabolic disease. And this is related to either reduced insulin, absent insulin, or reduced insulin effects. There are there's multiple types of diabetes. There's essentially four types of diabetes mellitus. We'll generally call the first two, we'll call type 1 diabetes mellitus and type 2 diabetes mellitus. Type 1, this is an autoimmune condition. This generally happens to people before the age of 30. It can happen after, but it generally happens before the age of 30. So autoimmune destruction of the beta islet cells. If you destroy all your beta islet cells through an autoimmune process, your body is attacking itself. You make absolutely no insulin. This is called an absolute insulin deficiency. In order to treat this type, you have to give insulin replacement. If insulin replacement is not administered, a person will die. This requires insulin replacement. Type 2 diabetes there's a catchphrase for this one that will tell you exactly what it is. It refers to insulin resistance. So you still make insulin, but it doesn't work as well as it should. And if it doesn't work as well as it should, it's an insulin deficiency, but it's not absolute. There's still some effects of insulin. This is a relative insulin deficiency. In this case, oral medications can work often. Sometimes diet changes can work. Or lifestyle changes. The other major type of diabetes is gestational diabetes. This is diabetes that happens during pregnancy. And this is happening during pregnancy in people who are not previously diabetic. This developing gestational diabetes significantly increases the chance that a person will develop type 2 diabetes in the future. It is a risk factor for developing type 2 diabetes. So when there's actually a fourth type of diabetes, like drug-induced, or other medical conditions. This generally is related to steroid medications. Now, I'm not talking about things like testosterone. I'm talking about things like corticosteroids, like prednisone. These are well-known medications that they're well known to increase blood sugar levels. I'll tell you a little bit about the classic manifestation. Actually, I'll tell you a little bit about this. Type 1 diabetes generally happens in age before 30. This is not a hard and fast rule. Generally happens in age greater than 30. Also not a hard and fast rule. You can get either at any, well, not really any age, but you can, usually it's adults get type 2, more children, adolescents get type 1. But again, it's not hard and fast. So I'll tell you the classic manifestations of diabetes, and there are four classic manifestations. And this is generally related to more type 1 diabetes, but it can happen in serious type 2 as well. So the classic manifestations. First one is something called polyuria. Polyuria. This is excessive urination. Poly mean many, urea meaning urine. So excessive urination. This is related to the high blood glucose. That will go when the kidney filters the blood, all that blood sugar goes into the kidneys, the tubules of the kidneys, and it acts as an osmotic agent, drawing water in to the tubules in the kidneys and eventually being eliminated as urine. So more water than usual gets drawn into the urine. Acts as osmotic agent in the kidneys. Well, you can imagine that someone's going to start getting dehydrated with this. They're going to lose more water. And you can imagine that with the loss of water, well, and there's actually two mechanisms for this next one, something called polydipsia. Poly, many, to drink. So it's excessive thirst or dipsia thirst. Excessive thirst. Two mechanisms. Number one, due to the dehydration from the polyuria, but also it is related to the excessive blood sugar levels is going to stimulate the thirst center in the hypothalamus. Excessive blood glucose stimulates thirst center in the hypothalamus. And this thirst center is related to the amount of dissolved stuff that's in the blood. So that higher blood glucose, there's more dissolved stuff in the blood, so it makes you thirsty. Well, the cells are also starving. They're getting no energy. They're not getting anything. So there's also polyphagia. Many to eat. So this is excessive eating. And this is due to the cellular starvation. Cellular starvation from the low insulin. So no insulin, you don't get the sugar in the cells become starved. It stimulates hunger. And then the last classic manifestation is weight loss. And the weight loss is for a couple of reasons. Number one, there is due to dehydration. Water carries with it weight. And then also, your body starts to break down fats, muscle, to try to get that into the cells for energy, but it can't. Insulin's required for that as well, but it breaks it down and you lose your lean muscle mass and you lose a lot of the energy stores. So breakdown of fat / loss of muscle. And that is going to lead to um, um, a reduction in the weight. So notice that there is polyuria, polydipsia, polyphagia. There's three polys and then weight loss. And we often will refer to this as like the classic manifestations are the three polys plus weight loss. This generally happens in type 1 diabetes. Type 2 diabetes, because there is some insulin, your body, you may not know that you have type 2 diabetes. Type 2 diabetes is often asymptomatic for years. This is one of the reasons that we do regular screening blood work. After a certain age, though, your doctor or your nurse practitioner is going to check your blood and your blood sugar levels. So the really interesting thing here is that often type 2 diabetes mellitus is asymptomatic for years. So the real question is, why is diabetes dangerous? Why is it dangerous? So why is diabetes dangerous? So the first one is, well, type 1 diabetes mellitus. Well, the problem with type 1 diabetes mellitus is that there is no insulin. So your body starts to break down fat. For energy, because your brain needs either glucose for energy, or it could also use the breakdown, the product of the breakdown of fat for energy. The problem with this is that the byproduct of the breakdown of fat is something called a keto acid. It's something called beta hydroxybutyrate. So it's a keto acid. And the problem with acids is that they are acidic and it lowers pH. And it lowers pH so severely that it puts your body into a state of acidosis. One of the most important things within our regulation of our physiology is our acid-base regulation. If our pH goes even a little bit outside the normal window, our enzymes stop working. All of our cellular processes shut down. A normal pH in the body, now it's not 7. 7 is very, very abnormal. Normal pH has a range of 7.35 to 7.45. Anything outside of that range, and you get very sick very quickly. State of acidosis is going to bring your pH down. I've seen people in this state of acidosis with diabetes, and their pH is sometimes 7. I've seen 6.9. I've seen 6.8. This puts people into the intensive care unit, and it is life-threatening. And it's all related to those keto acids. Now, when somebody is in that state, it is one of the diabetic emergencies called diabetic ketoacidosis. DKA for short. So it's the breakdown of the fat, you make keto acids, and you go into a state of acidosis, so diabetic ketoacidosis. At the same time, remember, you have that polyuria, you're losing a lot of water, you're getting dehydrated. People are not only in a state of acidosis, they're also in a state of going into shock with their blood pressure can't be maintained because they're losing so much fluid. So it's a life-threatening emergency. Without treatment, this is the reason that people died when they got type 1 diabetes before they discovered insulin. Without insulin replacement, it leads to death. There are other reasons why diabetes is dangerous over the long term. So specifically like type 2 diabetes where the blood sugar is just slightly elevated or a little bit higher than normal, but it's over a long period of time. And the reason for that is that high blood glucose is toxic. It's toxic to several areas in our body, specifically the areas that have tiny little blood vessels or tiny little nerves. So it's toxic. It essentially sort of uh, causes there to be damage to cells. And the toxicity occurs in three major areas on a small vessel level. The first area where high blood glucose is toxic is the retina of the eye. Essentially, high blood glucose leads to inflammation and factors that stimulate new blood vessel growth. The problem with this is that new blood vessels with inflammation, these new blood vessels are not made very well. They're not made very stable. So the new blood vessels are not stable and they rupture. They tend to rupture, they tend to bleed and rupture plus bleed. And this can lead to blindness. There's a lot more cellular things that are going on here, but we're not really going to get into like the nitty-gritty cellular stuff. This condition, when it's related to diabetes and there's a disease at the back of the eye, the retina, we call it a diabetic retinopathy. So diabetic retinopathy. It's also toxic to the kidneys. Tiny little tubules of the kidneys and the capillaries of the kidneys. So you get inflammation of capillaries. And this leads to, the kidney is really important for filtration. So this leads to an abnormal filtration. And eventually this is going to reduce kidney function. And kidney failure. People end up on dialysis from diabetes all the time. This condition is referred to as diabetic nephropathy. Then the last area on a small, tiny blood vessel perspective are the small little nerves. Now, these aren't necessarily blood vessels, but they're the tiny little nerves. So it leads to inflammation in small nerves. And these small nerves can either be the sensory nerves. Sensory nerves are going to result, if they get affected, you get decreased pain, decreased temperature sensation, decreased vibration. You might think, oh, that's interesting, decreased pain. I don't like feeling pain. But pain lets us know that something's wrong. And if you don't know that something's wrong, you can injure a part of your body further, and it can lead to serious complications. And that's actually what happens in some diabetes. There's also the autonomic nerves, the ones that aren't under our voluntary control. So you can get decreased stomach emptying. You can get, and one of the really common places where autonomic function is affected is um, men will often get erectile dysfunction. This condition is referred to as diabetic, not the erectile dysfunction specifically, but the nerve issue. Is called diabetic neuropathy. When you read this in pathophysiology books, they're going to refer to these are the complications of diabetes. These three complications are referred to as the microvascular because they're the tiny little blood vessels. Microvascular complications. The problem is that diabetes can also affect the large blood vessels. And the places where we're most concerned about the large blood vessels are those blood vessels around the heart, so the coronary blood vessels, and the cerebral blood vessels, those around the brain. So it can also affect large blood vessels. And we refer to these, because they're the large blood vessels, we refer to these as the macrovascular complications. The two most important areas where we're going to affect these larger blood vessels is in the heart. So these are the coronary vessels, and this will lead to heart attack. It can also affect the brain, the vessels around the brain, which are the cerebral vessels, and this leads to stroke. The reason that this happens is that increased blood glucose increases the fatty deposits that happen in arteries, specifically these two groups of arteries, because the high blood glucose increases fatty acid deposits in arteries. We're going to talk about this probably next week. This process of that sort of fatty acid inflammatory deposition in the arteries is a process called atherosclerosis. So diabetes affects a lot of places. It also affects the ability of the immune system to function properly. So we often hear about people with diabetes having being in an immunocompromised state. And that's because the increase in blood glucose decreases immune function. This is a very complex reason for this. Everything about the immune system is very complex. But just trust me on that one, that the increased blood glucose decreases immune function. So you can see how this could get really out of hand with all of these complications. It can get really out of hand very quickly. So let's say, for instance, we have a diabetic person. And let's say, for instance, they have retinopathy. and they have neuropathy associated with diabetes. So let's say because of their retinopathy, they have a decreased vision. And let's say that they are, I don't know, they're clipping their toenails, and because they have a neuropathy, they can't feel a lot of pain in their extremities. So as they're clipping their nails, they can't see very well. They clip some of the skin, and they get a cut at the end of their toe. Well, they can't feel it. Can't feel it because of the neuropathy. And because they can't feel it, they don't know to stay off of it, or they don't know to clean it and keep it well cared for so that it can hopefully heal. The problem is they can't feel it. There's decreased healing in it. Because there's decreased healing, there's an increased risk of infection because it's an open wound. Well, the immune system's not working. So if it does get infected, it's going to get really infected. And eventually it can lead to an ulcer. Eventually, that ulcer and the infection can go right down to the bone. Um, and if that happens, potentially, you need to get it amputated. So you can see how just having a couple of complications of diabetes can lead to further complications with other parts of the body. Diabetes is a systemic illness. That's just one example of what can happen. There's lots of examples of things that can happen with diabetes. Let's talk about how we can manage diabetes. Diabetes can be managed depending on the type. If it's type 1, you need insulin. There's no way around that. You need insulin. But for management, if it's type 2 diabetes, we'll focus on type 2 right now. The first thing that you can do is lifestyle modifications. Diet changes. Usually this needs to be done in consultation with a dietitian. A diabetes educator. Physical activity is very important. Weight loss can be very helpful. This is a team-based approach. It's not just one doctor, one specialist that looks after somebody with diabetes. It's a team approach. There needs to be an eye specialist to check for changes in the eye. Perhaps a kidney specialist. Family doctors are really important, so primary care. Nurse practitioners. Usually you need an endocrinologist, an endocrine specialist. And oftentimes people with diabetes also need foot care to look for wounds, to look for ulcers, to look for changes, to cut their toenails, to make sure that everything is good. There are pharmacotherapies. So remember, again, type 1 diabetes, it's insulin, only insulin. But for type 2 diabetes, there are pharmacotherapies. And so this is just for pharmacotherapies. That's well, there's a few ways that these can actually work. The first thing, because this is insulin resistance, you can either help the insulin work better, or you can increase the amount of insulin that's actually being produced. So The first way is increasing the amount of insulin secretion. So these are going to, there's actually I'm going to just sort of give you a little physiology line here. So when you eat a meal, there's a type of substance called GLP-1, glucagon-like peptide 1. This glucagon-like peptide 1 is going to increase insulin. This is under normal circumstances. Well, this glucagon-like peptide 1, in order to make sure that you're not producing too much insulin, there's another substance that helps break down GLP-1. And this is called DPP-4. And DPP-4 is going to break this down. Break down GLP-1. So there's a couple of ways that we can actually help increase insulin using this mechanism. Number one, we can use a medication that blocks DPP-4. So we can use a DPP-4 inhibitor. And what this does, it allows GLP-1 to work longer and therefore increase insulin. That's one way to do it. GLP-4 inhibitors are called the gliptans. So there's, I'll give you an example of one. Januvia is one. That's a trade name. You can also, rather than allow your normal GLP-1 to work for longer by giving a DPP-4 inhibitor, you can actually give a medication that acts like GLP-1. So you could also give a GLP-1 agonist, and that's going to directly increase insulin. You've all heard of this type of medication. It's all over the news. Ozempic works like this. It's a GLP-1 agonist. That's one way to do it. So you increase insulin secretion. We call these insulin secretagogues. The second thing that you can do is you can increase the effectiveness that insulin has on the cells. So increase, so whatever insulin you have of insulin. The classic medication that you may not have heard of before, but you should probably get used to this name because it is used often in diabetes, is something called metformin. The type of medication that it is something called a biguanide. And what this medication does is that it increases the peripheral cell sensitivity to insulin. So we now have two approaches that we can use in type 2 diabetes, and there's a third one. We can either increase the amount of insulin secreted, increase the effectiveness of the insulin that you have. Often we use both. We'll increase the amount and the effectiveness. And then the third way is that we can also decrease the glucose reabsorption in the kidney. So the classic type of medication that is going to be used for this is something called an SGLT2 inhibitor. So if we look at the way that the kidney is set up, I know we haven't talked about renal physiology, but generally the way that the kidney works is that there is a tubule where filtered blood is going through. We're going to put that in yellow. In between that, where the blood's being filtered, there's cells that line that tube. And then on the other side of it, there's a blood vessel. That blood vessel is going to absorb stuff that you need to bring back into your bloodstream. And so in this bloodstream, in people who have diabetes, there's lots of glucose. So lots of these little green dots, lots of these green dots. And normally this glucose would be taken back up into the bloodstream. And the way that it gets taken up back into the bloodstream is that it uses a protein that is called an SGLT2. And it brings this glucose back into the bloodstream. These medications, rather than bringing it back into the bloodstream, people who have diabetes where their blood sugar is very high, you don't want that all that sugar to go back. So we give an inhibitor of these sodium glucose linked transporters, and you cannot bring the glucose back in. So you do SGLT2 inhibitors prevent glucose reabsorption and increase elimination of glucose in the urine. I think that's where we'll stop it today. Hopefully that gave you a really good overview of at least a couple of examples of normal physiology and then what happens when the physiology gets a little bit deranged in the disease process. If you have any questions, please don't hesitate to reach out to me. Happy to help in any way. And until next time, I hope you have a great week. And we'll continue next time with the nervous system talk. I think it's the nervous system. But I'll see you next time. Bye, everyone.